distinguished chairperson, and learned members of the House. As we all know that anatomically contoured periarticular plates for the treatment of proximal tibial fractures are fast becoming the standard of care. An anatomic fit should mirror the shape of the tibia in all the three planes. An anatomically designed plate can serve as a template for fracture reduction, can aid in fixation, and will minimize impingement on the overlying soft tissues. An anatomically contoured plate matches the shape of the proximal tibia, creates a fit that requires little or no additional bending. A low-profile plate facilitates fixation without impinging on soft tissues, and a taper plate shaft design allows for a minimally invasive technique. So we can see the proximal curvature of the plate should match the AP curvature of tibia. The shaft of the plate should match the curvature on the lateral surface near the metadiaphyseal junction, and the angle should match the posterior slope of the lateral tibial plateau. As shown by Holliday et al. In the American Journal of Physiological Anthropology, human tibia has been shown to be relatively more variable in anatomy than other limb segments. So can a pre-contoured plate serve as a fit, or will it create a misfit? Various authors have shown hardware prominence with anatomical plates to vary from 5 to 18%. For example, Sagittal et al. In Journal of Orthopedic Trauma showed that out of the 37 patients, 4 had hardware prominence, with 3 having a gap more than 5 mm and 1 having a gap greater than 10 mm beneath the plate. 3 had hardware irritation and 1 had implant removal due to the wound breakdown over the hardware. As we know that stiffness of the construct is inversely related to the third power of the plate distance from the bone. Also, these plates are stiff and thick and are not contoured easily and are negligibly compressed with screws. So we undertook a study to see how anatomical are these anatomical plates. We used 4 different plates from 3 different companies. We had 50 Indian dry tibia. All the plates were placed on the tibia by 2 independent experienced trauma surgeons according to what they thought was the best fit. The plate was kept within certain boundaries. On the lateral side, the plate was kept anterior and or superior to the proximal tibiofibular article surface and inferior to the edge of the lateral plateau. Secondly, the space or the volume of air between the plate and the surface of tibia was made as small as possible, giving priority to the proximal aspect of the plate. Finally, the plate was preferably aligned to the shaft of the tibia rather than the tibial plateau. 4 views of each fixation were taken: anterior, posterior, lateral, and view from the top. Tibia and plate fit were analyzed in 3 planes: sagittal, alignment with tibial plateau and shaft; coronal, volume of free space between plate and bone; and axial, match and curvature between proximal part of the plate and tibial plateau. View showing view from lateral and top. Our observations: in coronal alignment, 3 modes of fitting were seen. Flush fit, if the volume of space in the middle and distal part of the plate was similar. Spanning fit, if the volume under the middle portion was larger than under the distal portion of the plate. And impingement, if the distal end of the plate had more volume than the middle part. Photographs showing spanning fit, impingement fit in the axial plane, again spanning fit, impingement fit, again a spanning fit. Spanning is a problem in the lateral plates because plate protrudes into the anterior compartment. It may cause increase the chances of compartment syndrome. It may impair wound closure. Plate also loses the capability of buttressing. Also, it's more difficult to pre-bend a spanning plate. Also, as multiple bendings are required, it can result in substantial weakening of the plate. In sagittal alignment, 2 angles were measured: the plateau alignment angle between horizontal axis of the proximal part of the plate and the posterior tibial slope, and the shaft alignment angle, the angle between the vertical axis of the shaft of plate and the shaft of tibia. Photograph showing the 2 angles. If both of these angles were less than 2 degrees, the plate was said to be aligned in the sagittal plane. Axial alignment, same, had the flush, spanning, or the impingement fits. Photograph showing impingement in the axial view, spanning, impingement. We saw that in the coronal plane, most of the plates were spanning. Only few were flush fit. In sagittal plane, most were aligned, and again in axial plane, 2/3 were in flush fit, and rest were mostly in impingement. To conclude, recognizing and understanding the substantial variation in fit that exists between anatomically contoured plates, it might be worthwhile for developing proximal tibial plates specifically for Indian population. validating this study by having a larger multicentric study group. These plates should be used cautiously when used as an indirect tool for reduction of these fractures. Also, other parameters of reduction should always be considered due to existence of substantial variation in the fit to prevent malreduction of fractures and soft tissue impingement. Also, templating on X-ray of the opposite side may help in preventing this problem, especially spanning in the sagittal plane. Limitations of a study were that cadaveric dry tibia were used. Plates were placed on non-fractured cadaveric bone. Intraoperatively, positioning the plates would be more complex. Also, our study had a very small sample size. Thank you.